Hi, my name is Dr. Jerome Meller. I'm a general practitioner and work in Ballina on the north coast of New South Wales. Advanced care planning is about making future decisions at a time when, for some illness or accident, you no longer have the capacity to make decisions for yourself. This really has two arms. The first is through making decisions for yourself, so through an advanced care or health directive in the written form or advanced care plan in the verbal form. The second arm is families or guardians making decisions for someone who has lost the mental capacity to make decisions for themselves through illness or accident. In this first video, we're going to discuss the following: developing, perhaps for the first time, a freely accessible and web-based series of education videos on advanced care planning using a dedicated website, printable information leaflets, an advanced care directive and other tools and resources. I'll discuss what each of these videos in the series is about, what they're trying to achieve and who they're for. We're also going to look at how we can promote advanced care planning by looking at some examples. And lastly, we'll be discussing the ethics of advanced care planning. The second video in this series is about helping families and guardians to make decisions for their mentally incapacitated relatives. This video is called 5 Steps. In brief, these are helping families understand that they have the right to refuse life-prolonging treatment and choose palliative care if they wish, giving them information about the nature of life-prolonging treatments in the 21st century, and remember, it's not just about CPR and life support options, helping them navigate the meaning of prognosis or natural course of illnesses, in particular in dementia, giving them confidence in assessing what the patient themselves would have wanted by understanding their values, beliefs and goals, and finally, using written palliative care directives when life-prolonging treatment is no longer wanted. It seeks to develop a modern, easy and above all teachable method for doctors and nurses. The accompanying information leaflet about the 5 steps is only 2 pages long and helps to standardize information given to relatives. But the video is equally accessible to families and guardians making decisions for patients with dementia or those who are admitted to hospital with acute confusion or altered states of consciousness. The third video is about completing an advanced care or health directive. It goes through all the main issues of the day as well as various life-prolonging treatment options, and explains the importance both of involving your family or carer or guardian as well as your normal treating doctor. Although this video demonstrates an advanced care directive that I have written and used for several years successfully in practice, it could be used to understand the issues in any care directive that you might use. It covers many of the common scenarios where you might lose capacity to decide and the modern choices in consenting to life-prolonging treatment. It is useful to train those professionals promoting ACDs to patients as well as to members of the public who want help completing them. The Advanced Care Directive is largely self-explanatory. It can be printed from the following websites, and it's worth noting that even if an individual doesn't want to complete the directive himself, he can always use it as a template to discuss the issues of future care with his family. The fourth video is about mental capacity assessments or testing. It goes through what the difference is between mental capacity in normal aging and dementia and confusional states, and goes on to explain how you assess this capacity for perhaps consenting to an operation or treatment or even doing an advanced care directive. It also explains the importance of not using mini mental tests where they're merely tests of memory and attention for assessing capacity. We go on later in the video to discuss what I would call retrospective mental capacity testing. These days it's increasingly common for medical professionals to be asked to assess someone's capacity as it existed several years before in the cases, for example, of in will disputes in order to present them the possible capacity in several years previous to the court. How can we promote advanced care planning? We're now going to use a couple of examples to show how advanced care planning can be promoted through standards, protocols, tools and resources on the web. Let's say a frail 84-year-old lady is admitted to hospital from her home for the fourth time in 12 months. She has chest, heart and kidney problems. There's a substantial risk that one day she'll be admitted confused, unconscious or even with a cardiac arrest. How do we ensure that her rights to make an informed choice about treatment have been attended to before she loses capacity to decide? It should be standard practice in hospitals that all at-risk elderly patients are offered advanced care planning information and even perhaps an advanced care directive, so that for future admissions their treatment options have already been decided in advance in case of mental incapacity. And of course, this is not just an issue for hospitals, it is also an issue for nursing homes. And they too should have standards of accreditation where they have to offer information on advanced care planning and substitute decision making for families to make decisions for those who can't make them for themselves. Whether one uses clinical triggers or risk assessments to see who would benefit from them, or that they might be offered to all over a certain age, perhaps 70 years plus, is open to argument. Triggers might be for newer diagnoses of dementia, terminal cancer, or severe COPD. Perhaps it would be easier to offer them to all elderly. After all, people are admitted with severe head injuries or strokes without any previous risk factors or triggers. A 76-year-old man is admitted to a hospital from a nursing home. He has been there for 2 years, he's still up and about and suffers with moderately severe dementia and has not the capacity to make decisions for himself. A standard myocardial infarction treatment protocol is applied to him and he is admitted to coronary care unit and is subsequently discharged on aspirin, beta blockers and a cholesterol lowering drug used to prevent further heart attacks and prolong life. Is this treatment in his best interests? Has the family been given proper informed consent? What are the standards, protocols, tools and training to ensure these questions are adequately attended to? The tools and training in the 5 steps video need to be backed up by standards of informed consent and effective clinical protocols to hospitals. In most hospital management protocols, there should be a section concerning patients with acute confusion or dementia, where it's compulsory that doctors or nurses discuss with the families or guardians issues discussed in the 5 steps video. Essentially, this should be a part of routine care, not just left to an individual doctor's discretion. Similarly, in nursing homes, many life-prolonging treatments are given and continued for many years for patients with dementia and vegetative states there. It should be part of standards of accreditation that nursing homes should have to give information on substitute decision making in the 5 steps videos to families and guardians. These days, training is frequently given to doctors and medical students about advanced care or health directives. It's not so common for training to be given about substitute decision making, and this should now become the norm, whether this be a medical school, general practice training, or an intern training in hospitals. Let's talk about medical ethics and how they underpin advanced care planning. There are 4 core values in ethics that we need to discuss first. These are beneficence, doing the most good, non-maleficence, doing no harm, justice, and autonomy. When we're talking about ceasing life-prolonging treatment and saying that this might be in their best interests, how do we conclude that it is better for them to die rather than live? Is life sacrosanct? How do you resolve the clinical conundrum, say, where it is better not to treat someone with severe dementia and let them die, or to treat them where they will live for months and years as a vegetative state-like patient? Which choice does most good, and which choice does least harm? In Western society and law, these issues are resolved through the application of justice or equal treatment and creating autonomy or self-determination for the individual or the families involved. You can create autonomy or self-determination for individuals or families by giving information about prognosis in illness, by information about the nature of lifelong treatments, by what is meant by the insecurities in outcomes, that ceasing a treatment may make no difference at all. It may mean that the patient just becomes more disabled through a stroke, or it may indeed mean that a patient, for example, has a stroke or heart attack and dies. Justice is often described as treating people fairly, or everyone being entitled to equal treatment. Let's take our 76-year-old man with dementia. He is entitled to equal treatment for somebody much fitter and younger than himself. But equally, justice implies that that same person is entitled to equality in informed consent. So for the 76-year-old who has dementia, their family are entitled to know certain facts about prognosis and treatment which might not be relevant to somebody who was mentally fit and 50 years old. Of course, there are other ethical issues which bear on these decisions. The law, health authority and medical council guidelines, the wishes of different family members, resources available for treatments, etc., etc. You could have two very similar clinical situations yet come to opposite conclusions. There may not be a right answer, just an ethical one for that individual. This series on advanced care planning is not just about educating professionals and the public and about trying to change standards. It's really about trying to revolutionize the way we care for our elderly in hospitals, the nursing homes, and in the community. I hope you enjoy the rest of these videos, and many thanks to North Coast Medicare Local for producing this series.